Thank you for joining. This is the August 1st webinar of the Connecticut Health Policy Project on updates to URAC'S to Patient-Centered Medical Home Program. I am Ellen Andrews, Executive Director of the Policy Project, and we are fortunate to have Christine Layden, who is the Chief Accreditation Officer and Senior Vice President at URAC. And she'll be describing URAC's new Patient-Centered Medical Home Recognition Program. We want to thank Christine for joining us. To best use our speaker's time and to get as many questions answered as possible, we'll be asking you to type your questions into the question pane on your screen. We will answer your questions at the end, but you can type them in at any point during the webinar. So I will turn it over to Christine.
Thank you, Ellen. It's a pleasure being with everyone today. If it's possible, if everyone listening on the phone could use their phone, that'd be appreciated. We're hearing a lot of background noise. Next slide, please. Next slide. Today's objectives for the webinar are to describe who URAC is, also provide some market information related to where medical homes are today, as well as look at an overview of URAC's patient-centered healthcare homes. And our programs include a toolkit, the Auditor certification, as well as the actual standards that a practice is reviewed under, and also to just summarize where we are with our patient-centered healthcare homes today. Next slide. Next slide. Who is URAC? Well, URAC is known in the industry as an accrediting body. We've been in business for 21 years. Our mission is to promote continuous improvement in the quality and efficiency of healthcare management through the processes of accreditation and education. We are a nonprofit. We have a broad-based governance structure which includes providers, consumer reps, which are very important, managed care organizations. We have regulators on our board from the National Association of Insurance Commissioners, as well as there's a quadrille of representatives from on our advisory committees that serve in a volunteer capacity, such as our standards committee, our accreditation committee, as well as we currently now have openings on our measures advisory committee. Our focus in the healthcare management space is vital that we are the voice of the consumer in consumer protection and empowerment, and all of our programs are geared at improving and innovating healthcare management. Next slide. URAC was founded in 1990, as I mentioned, and we frequently get a question, what is URAC and what does URAC stand for? URAC originally was branded as the Utilization Review Accreditation Commission because we were the first accrediting body that looked at utilization management. Those were back in the days when there were not established guidelines related to the denial of care or the process of utilization management. Since that time, we've expanded to 27 accreditation programs across the entire continuum of care. And as a result, we currently have over 500 organizations that operate in the United States and internationally under URAC standards. It's important to note that you'll see URAC referenced in requests for proposals. We also have federal and state recognitions. For example, the Office of Personnel Management recognizes URAC's case management, the Department of Defense, and the VA system, as well as URAC has Medicare deeming. Next slide. When we look at the continuum of care, URAC has set up our standards to look at quality and accountability across the continuum of care. And that means that the patient-centered healthcare home is managing a population from wellness to at-risk to acute episodes of care, chronic conditions such as diabetes or asthma, and catastrophic events which might occur as a result of an injury in the workplace or a disability as a result of an injury or lifetime chronic illness that has caused alternate functioning level, as well as managing end-of-life care. And these programs include health website, for example, health call center. A health call center program looks at the Ask a Nurse lines for triage, and we're starting to see some of that information being conducted via web-based interface, as well as pharmacy quality management standards for PBMs, DTM, specialty, and mail, and how they interface with the patient-centered healthcare home. And then we also have a suite of programs that are specific to the workers' comp space, such as workers' comp PBM, workers' comp UM. And URAC is the only accrediting body that offers independent review accreditation as well as health call center accreditation. Next slide. As we develop our standards, it's important to note that we don't develop our standards in a vacuum. It's not the staff writing the standards. We actually have an advisory committee that looks at all of the stakeholders in the industry and how the standards would impact them. So, for example, when we developed our patient-centered healthcare home standards, these included over 60 stakeholders from physician medical societies, nurse practitioners, consumer reps, as well as government reps, employers, and health plans. We then put the standards out to public comment, and similar to a legislative process, we have a 60-day public comment period. The standards are then revised, and then we actually beta test the standards, and where we find gaps in the standards, we want to make sure that the standards aren't too high or too low, and that the standards are then revised again, and then the standards are approved by URAC's Board of Directors. Next slide. And let's talk a little bit about the medical home and what we're seeing in the industry today. Next slide. Well, in a study that was done in March 2011 by the American College of Physicians, you'll see that the areas on the map in the dark green area, depending on your screen resolution, really apply to both a private payer as well as the medical home pilots such as Medicaid and CHIPS medical homes. The areas in red are related to the Medicare population. And then there's, I guess you would call it Muppet green, and these are areas that are identified to have a Medicaid program related to medical home initiatives. It's important to note that the combined commercial and Medicaid or Medicare population, medical homes, are increasingly growing. And pretty much across the United States, you can see medical home activity occurring. So medical home is no longer a concept. It is actually fully operational across the United States. Next slide. Now, what are some trends related to medical home? When URAC did market research related to the development of medical homes, we found that there were a number of programs where establishing medical homes increased slightly from 34% in 2009 to over 40% in 2010. And it's also important to note that over half, 53% of the health plans that we work with have established networks of medical homes, equating to about 59% of the physicians in their primary care network. In the next 12 months, it's anticipated that the medical home growth will continue to grow, and we expect to see that growth up until 30%. Now, the wild card in all of this is where we will land with incentive programs through the states or through the federal government related to funding for incentives pertaining to medical homes. We've also seen consistent movement in the health plan market space related to medical homes. And on this slide, you can see a study from the Healthcare Intelligence Network that looked at measuring how are medical homes evaluated between the health plan component as well as the difference in what a physician practice measures. It's important to note that we see consistently that a health plan is looking at more of a comprehensive review that includes clinical outcomes as well as patient satisfaction, but the physician practices are focused more on clinical outcomes, and we're starting to see more adoption of electronic health records, but patient compliance is less likely to be measured. Patient compliance is an area of interest and an area that requires collaboration between the health plan, the actual patient and their family, as well as the payer and the employer in that space related to patient compliance. We are hearing a lot of dialogue related to how incentive programs are measured around patient compliance and satisfaction, but we do believe that this is a shared responsibility among the payer, the employer, the consumer, and the practice. Next slide. So let's talk a little bit about how this information helped URAC develop our patient-centered healthcare home overview. It's important to note that we began our development in March of 2010, and as I mentioned, this included over 60 thought leaders in the space, and our initial rollout of our patient-centered healthcare home program started in 2011, and in June we recently released our achievement program for the patient-centered healthcare home. Next slide. All of our programs start with a definition of what a patient-centered healthcare home is. It's important to note that, notice we are not calling our program the medical home because we believe in consumer protection and empowerment. Therefore, our program is called the patient-centered healthcare home, whereas the healthcare team is working with the patient to ensure that they're receiving the right care at the right setting and at the right time. In the URAC model, we recognize the importance of improving access to care, and therefore we created the team approach to the patient-centered healthcare home, and that this is clinician-led. In the URAC model, both a nurse practitioner, physician assistant, or the physician is recognized. Also, URAC recognizes the definition of the Institute of Medicine and the quality aims. So the standards are aligned with those key components of the Institute of Medicine's patient safety. Those include safety, effectiveness, patient-centeredness, that the care is provided in a timely manner. So, for example, ensuring that lab values are responded to and that there's notification to the patient about their results, whether they're abnormal or that the tests are okay. Also ensuring that there's efficient and there's the ability to ensure that there's replication in the practice through standardized organizational structures, policies and procedures, and how an electronic health record may be used, as well as the principles of total quality management. It's also important to note that we have also looked at PCHCH and ensuring that there is appropriate access to care to avoid disparity in serving populations, that the care is culturally sensitive, and most importantly, that the practice utilizes quality management principles to look at their access to care through appointments, as well as weighing to improve their coordination of care and recognizing the complaint process that exists between the practice and as well as the payer. Next slide. So let's look at the URAC Patient-Centered Healthcare Home Program. Our program consists of 4 components. In 2010, we released our program toolkit, and those include all of the standards related to the patient-centered healthcare home. And these include the practice assessment standard, as well as a survey information resource for doing satisfaction, and some performance measures. These are available online in the URAC bookstore, and the survey and the performance measures are at no cost, but I believe the patient-centered healthcare home assessment standards are at a low fee of $49. We then looked at the scope of an increasing number of medical homes across the United States, and we made a strategic decision to do 2 things. Practices are either early adopters of the patient-centered healthcare home, or they are just beginning transformation into a patient-centered healthcare home and need the assistance of and guidance of familiarity with a consultant to perform the patient-centered healthcare homes. And what we learned from the market was that practices wanted to be assured that the professionals that were coming out to either transform the practice or to conduct the survey for their certification had to have some type of clinical background. So therefore, URAC made a strategic decision to create an auditor certification. And under this program, we are certifying the organization that supplies the auditors to either provide guidance to the practice on transforming into a patient-centered healthcare home, or if it is a health plan and wants to do some quality improvement with their practices, their quality management department can supply auditors as well as the fact that geographically, with the estimate of 52,000 practices across the U.S., we had to have bandwidth to perform all of our achievement audits. So we also developed the program where either a URAC auditor conducts the practice achievement or a URAC certified auditor from the organization conducts that. What's essential to note is that the auditor certification includes the core accreditation as well as annual training for the auditor. And we then provide a primer to the auditor or to health plans or to physician hospital organizations, whereby it's a licensed subscription that's web-based technology where practices can be benchmarked against their performance with the patient-centered healthcare home standards, or a health plan could track quality improvement efforts related to the patient-centered healthcare home standards. And then in June of 2011, we were pleased to announce our practice achievement, whereby a practice receives a designation of achievement for a 2-year period for following the URAC patient-centered healthcare home standards. And that program has 2 designations. One is achievement, which is meeting the 28 minimum standards, as well as achievement with electronic health records for meeting the meaningful use requirements. Next slide. The foundation and the principles of our patient-centered healthcare home are aligned around 10 key principles. And this starts with a patient-centered care team culture, so that the care in the practice is coordinated based on the clinicians in the practice, ancillary staff that's in the practice, as well as coordinating with specialists that are involved in the patient's care or community resources. And also ensuring that there's appropriate access to care with visits, as well as access to the network of the health plan. But the key principle in the URAC model is that there is individual care planning, and we're trying to promote care coordination that is safe and efficient across the continuum of care, and that the principles involved in cost-effective care are also utilized, and that there's transparency to the consumer that they are in a patient-centered healthcare home, what their rights and responsibilities are, and if they would like to no longer participate in the patient-centered healthcare home, that they can do so. Next slide. What is also a key component is that in a patient-centered healthcare home, we are managing the consumer across the continuum of care. A key component of PCHCCH, as well as in the patient-centered healthcare home model, is the fact that URAC requires wellness activities, as well as looking at disease management interventions, and that there is support through a case management program or care coordination activities when there is a transition of care as the consumer has a chronic event or an acute episode of a chronic illness, so that the care is coordinated to ensure that the patient-centered healthcare home is providing the necessary resources and is communicating with the interdisciplinary care team. Next slide. So the wellness standards framework was applied to the patient-centered healthcare home model. There is a standard that requires a health risk assessment, that the population health is being managed, that there is risk types identified in the population served, and that most importantly, based on the health risk assessment, that the practice has a continuous process for applying the interventions related to the health risk assessment across the population for the individual patient, so that there is avoidance of errors or gaps in care. Next slide. As I mentioned, the focus is on healthcare, not limited to disease, and that the patient-centered healthcare home model at URAC is focusing on the caregiver and the family, as well as the individual and their support system. That there is a requirement for a patient-provider agreement that is actually executed between the practice and the consumer and their caregiver. That they can expect to have an enhanced care coordination, and that there's ongoing communication, whether it be through an electronic health record or through a dialogue that occurs in the office, as well as ongoing communication. Looking at health literacy and adopting the individualized care needs to the appropriate level, and most importantly, respecting cultural differences and addressing and having flexibility to adopt to that. It's very important to note that URAC was recognized in the patient-centered healthcare home by the MGA, the Medical Group Management Association. We were recognized as meeting all the elements that were evaluated. They evaluated the 5 accrediting bodies related to that, and it's important to note we met those elements, and we also do require an on-site audit of the practice. If you go to the MGMA website, you can see a link to that information. So let's talk a little bit about the program toolkit and the auditor certification. Next slide. So as I mentioned earlier, the program toolkit components include the practice assessment, and those standards address the specific requirements that a practice is surveyed on, as well as the survey information resources from the CAP survey, as well as the pending release of the Medical Home Satisfaction Survey, and some performance measures information resources from ARC that are available. Next slide. So based on the auditor certification, it is a 3-year certification program that includes the core accreditation. Each of the organizations are issued a URAC on-site audit tool, and what's important to note is that the organization goes through the core accreditation process, which addresses the standards for business continuity, staff training, the HIPAA requirements, information management, and most importantly, that there is an inter-rater validation done by URAC of the auditor performing a practice on-site prior to the designation of a URAC PCHCH auditor designation. And then annually, the auditors from the organization must attend training. Next slide. So who can become an auditor? It's important to note that the URAC model only recognizes licensed healthcare professionals, and these professionals have to have within their scope of licensure the ability to perform care coordination. So therefore, a registered nurse meets that requirement, as well as physicians and pharmacists. Additionally, the certification process does include the core accreditation on-site visit, as well as at year 2 of their accreditation cycle, we do a monitoring on-site and random inter-rater validation visits. Next slide. Our primer is what the auditors utilize, or what a health plan can utilize, or a hospital health system can utilize to look at self-assessments conducted on behalf of the health plan or the practice administrator as a component of a performance improvement system. So this is one way that the auditors are supported, but as well as individual self-assessments could be conducted by a health plan of their network to benchmark their practices as to their readiness for a patient-centered healthcare home. And this example on this slide is an actual view of the primer whereby you do a check mark, and it does graphs for you as well on benchmarking your practices, or it can be used as a guide for preparation on transformation to the patient-centered healthcare home. Next slide. And now let's talk a little bit about our achievement. Next slide, please. Our practice achievement has 28 comprehensive standards that utilize the URAC Patient-Centered Healthcare Home Standards. And in those standards are mandatory requirements and essential. There are 7 mandatory standards. And then we have standards that are aligned specifically with meaningful use. What's important to note is that all practice offices are audited. They receive a 2-year certificate of award to the practice. It's also important to note that we have a public report at URAC. So you'll be able to go to the URAC online directory if you're a payer, patient, employer, purchaser, or a regulator. You can download the achievement summary report, and it displays the overall score for the practice, as well as which standards were met or partially met in the public domain. We learned from our market research that practices did not want to have to submit multiple reports to different entities. So this was one way that URAC is making it easy on behalf of the provider to disseminate information. We also have two designations. The first is achievement, and this is meeting the rudimentary standards related to the patient-centered healthcare home. But, however, this practice might only be using only a component of an electronic medical record and not all of the 28 meaningful use requirement elements. So we have a second designation called Achievement with Electronic Health Record. And these include that the practice is utilizing a certified electronic health record that's been certified through the ONC and NIST that's listed on their website. And then we also check to ensure, most importantly, that the practice is utilizing the certified electronic health record technology in the appropriate manner, so that when they're reporting out on, for example, their volume of e-prescribing, if for some reason they got a 0, it means that someone is not filling out the orders correctly or the reports aren't being run appropriately. Next slide. So our achievement is met when a practice achieves a 65% overall score and that there's 90% compliance with medical record documentation. And that can be either in the paper format or electronically. For the achievement with the electronic health records, they must meet the minimum threshold of the 65% overall score, but there has to be 100% compliance with the meaningful use requirement. And those 12 standards are aligned with 25 of the meaningful use requirements that are identified through CMS. Now, we also have plans that are using URAC'S achievement model as a component for pay for performance. So in order to do that, a plan can just designate that they meet the minimum achievement standards, or the plan can select additional URAC standards for pay for performance from the toolkit of the original standards in addition to the minimum of the standards that are required for achievement. And all of those standards are denoted in the achievement summary report. Next slide, please. So what are the modules in our practice achievement? Well, there's 7 key modules. We've always, URAC has something called the core standards, which are addressing the quality care management standards. And those components, such as policies and procedures, how the practice verifies the credentials of the practitioners in their group, and training, as well as the complaint process. And also looking at patient-centered operations management, such as the ability to have a patient registry, their hours of appointments, their responding. Then we also look at access and communication, the testing and referrals process, as well as the components of care management, such as linkage to community resources. Some practices have elected to have a linkage with a health plan that supplies a case manager to the practice. And then what we also have is advanced electronic capabilities, and that's the area where you'll find the meaningful use requirements, but you'll also see the linkage of the practice communicating to the consumer with their patient, with their own personal health record or through some type of secure email capability, as well as the domains of quality, performance, reporting, and improvement. And these are areas that address looking at their responsiveness, timeliness, their clinical outcomes of their practice. Now, the practice review can either be done by a certified URAC PCHCH auditor, or the practice can elect to have a URAC review staff who are all on staff at URAC perform the audit of the practice. They are rated on either fully meeting the standard or partially meeting the standard, but it's important to note that if it's a component of a pay-for-performance program and there are additional standards from the toolkit, our model is flexible to verify those standards as well. Next slide, please. So these are the mandatory standards that are included in the URAC'S PCH Patient-Centered Healthcare Home model. As you can see, rights and responsibility is a mandatory standard, as well as looking at access to service and information, and how the practices enhances access to services. For example, linkage to the specialists in the network, as well as identifying gaps and reporting them. How the practice follows up on referrals and tracking them. Also looking at the practice's ongoing care management protocols, such as when there is an aberrant finding, what happens. And most importantly, how care is coordinated for the transition of care. And that also includes medication reconciliation. At each key point or an event that is a transition of care, there is a standard that's required related to medication reconciliation. And then lastly, how the practice is tracking and reporting on their outcomes of their population. Next slide, please. This is a high-level summary that looks at all of the PCHCH practice achievement standards. And if you'd like, after the webinar, we'd be happy to send you the standards. And this is just a drill down of some of the key areas related to the modules that I mentioned in the previous slide. So for example, health literacy is individualized, knowing the individual health literacy level of the patient that they're serving. Under care management and coordination, you'll find both wellness activities as well as, again, the principal component of the URAC model is that there's individualized care management to the patient based on their assessed needs, their assessed health risk assessment, that there's medication review and reconciliation, and then also looking at the transition of care with a written health plan as well as appropriate use of clinical guidelines. Now, some of the self-management support and assessment tracking also includes how the practice encourages self-management, for example, whether it's obesity or anti-smoking that occurs. Next slide, please. Now, let's talk a little bit about the advanced electronic capabilities that is available. These include such areas as the electronic communications portal. This could be an email exchange, a personal health record, as well as looking at electronic prescribing and dispensing that is available. The other key area is that our model is flexible because we know that there has not been full adoption of the electronic medical records. Excuse me. So after the practice is audited, there is an achievement process summary. Excuse me for 1 second. Our allergies are in full bloom in Washington this weekend. It got very hot and then a little chilly this morning. So excuse me. It's important to note that you'll find that the practice achievement process summary is available online after a practice goes through achievement, and we'll be releasing those directory once our initial practices goes through the audit. These include our certified auditor contacts an on-site review, as well as the application is scored and reviewed by URAC, and then the summary report is displayed in our online directory. So even if a URAC certified auditor conducts the on-site review, URAC does a validation of that on-site to ensure congruence. And this is a summary slide that talks about how utilizing the toolkit or the primary practice can do an independent assessment, as well as the practice must submit their application within 6 months of purchase. There is an on-site review that's conducted. We then score it, and then a public report is available. However, only if the practice passes is the achievement summary report displayed in the directory. They do have the option to go through the process one more time. Next slide. So let's talk a little bit about URAC'S PCHCH program and any questions that you might have related to our standards. Another key component that we just want to emphasize related to electronic medical records or through practice achievement is to ensure that you're aware but there is a lot of personal health information that's being exchanged between a practice, a plan, or in some models in a self-funded arrangement. And it's important to note that consumers are assured of their rights and their HIPAA privacy and security. So URAC has been a long stander in the accreditation space for HIPAA privacy and security. And that is an essential component because consumers continue to have fear related to release of their protected health information, and it's ever growing with electronic medical records as well as going into their doctor's office. So we do have some health plans that have started and gone through the process for HIPAA privacy and security, and it's important to note that in the patient-centered healthcare home program, we are requiring the auditors to also meet the business associate requirements under our HIPAA privacy and security accreditation. Next slide. Now, what's the most important thing, and where is URAC going to go next with our patient-centered healthcare home? Well, we believe that the patient-centered healthcare home does set the foundation for accountable care, and that you'll start to see that the entire continuum of care, whether it be home health, hospital, a specialty pharmacy, or specialist care, or rehab, all have an interface with the patient-centered healthcare home. And that will be the foundation for accountable care, whether it is at the health system level, the health plan level, or in the group. And that all of the support services around a patient-centered healthcare home contribute to the success of both the practice as well as to the health outcomes of the patients that they serve. Next slide, please. So just as an overview, there are 4 components of our program. We also offer educational resources and support. So if you would like to go to our website at URAC.org, URAC.org, you'll also see that we're offering webinars as well as that we're available to come out and speak to different conferences and discussion groups. And that our program also includes both ensuring quality of the individuals that are auditing the practices as well as the standards related to supporting patients and their families and practices in our achievement model. Next slide. Also, the patient-centered healthcare home programs, because of the auditor certification and activities that a plan supports in care coordination, these activities may qualify related to medical loss ratio. Next slide. And now we'd like to open it up for questions.
That's great. I want to thank you very, very much, Christine. I want to remind people they can type questions into the question pane on their screen. But I'm going to take the organizer's prerogative here and ask a few. In terms of the auditor organizations and who the people who actually come out, I think that's a really important and different piece of URAC's standards. How do those site visits work, and how do you make sure that it's a meaningful visit but not a burden? And you also talked about helpful guidance, that it's not just an auditor who comes in and sort of comes around with probably a tablet instead of a clipboard now, but and just checks things off. But how is it actually helpful to the practice to have the auditors come in?
Yes, that's a great question. Thank you, Ellen. URAC's approach to accreditation or certification has always been educational. Our goal is to assist practices in their transformation so that when we do conduct the on-site visit, we have an agenda that's provided to the practice, and that we're also making suggestions and sharing of best practices that we've seen related to trends that might be of assistance to the practice and the patients that they're serving. The on-site visits are pre-arranged, they're scheduled, and they take about a day and a half to go through the standards. The bulk of the activity is related to the medical record audit, as well as we interview the staff that are working at the practice, and we do an interview of one of the patients as well that the practice identifies to ensure that the standards are being met. And as I mentioned, we do, if a practice does not pass the achievement program the first time, we do have a 6-month period where they can go through the process again to become ready, and that is an educational process as well.
I think that's, I like very much that you actually talk to a patient as well. Also, the privacy emphasis is very important. As, you know, representing consumers, they are very concerned about their privacy. I think that's great. A question that has come up a lot is, what does this cost to a practice?
You know what, I don't even know the pricing off the top of my head, but if anyone has a question related to that, you can email me afterwards and I can assure that it gets answered. However, we are competitive pricing to the other people that are in the space, that I can tell you. Okay.
Questions that have come up as well is sort of the integration. There have been concerns that a lot of standards don't necessarily aren't as appropriate as they could be for pediatric practices. And also, could you talk a little about the integration with other kinds of healthcare, particularly behavioral health?
Yes. Actually, part of our stakeholder group did include representation from the medical societies related to pediatrics. So the standards that are in place, you'll see in the achievement standards that they were adjusted to include the pediatric population as appropriate. So that's one way, so that the achievement is flexible to recognize both the adult patients as well as the pediatric patient, and in both cases, their family. And was there another component to your question?
Behavioral health?
Yes, behavioral health was integrated into the model because we, in our philosophy of developing the patient-centered healthcare home, it's care of the individual and their care needs. So we would expect the practice to be doing as part of their health risk assessment to include psychosocial needs, as well as when an issue is identified, ensuring that the appropriate community resources are addressed or specialty care. So again, the care is not aimed at one component, one dimension of illness, but it's looking at the whole person, as well as our definition of wellness does include psychosocial.
Well, great. I think that's all the questions. I don't know if you have anything else you'd like to add before we wrap up.
No, just thank you, and I'm sorry that I got a little bit of a frog throat there in the middle, but hopefully the pollen will go away soon.
Yes, I'm sure it's coming north to us. Thank you very, very much. And there's contact, yes, there it is, contact information. If people want more information, they can contact you with all their questions. I want to thank you very much. And the video and slides, I believe the slides from this webinar are already posted on our website at cthealthpolicy.org, and the video will be soon. Thank you very much.
Thank you. Have a great day.
You too.